Good morning. Thank you for the invitation once again. I have two things to disclose up front. I might have a hard time turning around because I have very significant back pain for some reason, so bear with me. And then the second one is I realized the prior talk and mine are a little bit in overlap with Lindsay, not for any other reason than I think we need to drill this idea to the families and everything for us all to be in agreement. I'm at Baylor College of Medicine at Texas Children's. We have a pretty significant Syngap clinic, although we're not a part of the natural history studies at this point, but I guess we are of other aspects. So I think this is important to understand kind of what each one of these aspects is. My priority in the presentation is really mostly for newer families coming into this that are not quite as seasoned as some folks who have already gone through the whole alphabet every single term. You know, you've read NHS, you've read, ABA, RBT, this and that. Everything is familiar terms to you. So when you first get a diagnosis, how many folks over here perhaps have had a diagnosis in the past year? By show of hands, there's a few folks kind of popping around. I know that it's in and of itself overwhelming. You have to kind of plan what is going on and what do I need to focus my energy on. And I would say, the priority is always going into the standard of care. I see my slides didn't transcribe quite as nice as I thought they would. But then you start to enjoy the participation in the community and realizing that there's an opportunity for these natural history studies and as well for what Lindsay just mentioned about the clinical trials. But what is the standard of care? That is really the principal aspect of what we need to review and to participate in. It is really establishing that collaboration with your neurologist, the person that's really going to guide you through caring for your child in the needs that have to do from epilepsy over to developmental and behavioral care, right? Now, it really depends on your child's individual needs. I realize that for Syngap, as for many other conditions, the differences in, let's say, the severity of one end of symptoms versus the other can vary so much that you might need more support in your developmental aspects than you might need in the epilepsy aspects at some point in time, or vice versa. Now, depending on the setup of your clinics, on the setup of your regional, let's say, available resources, as well as globally speaking, you may have a primary local neurologist versus more of a multidisciplinary or, let's say, focused neurologist. So there's a wealth of clinics, for example, in the US, a number of others outside of the country that are, in a way, centers where we collect more information. We have folks who have seen a number of individuals with defined conditions, Syngap being one of them, of course. And that makes it so that you have a certain someone who has a pretty significant level of expertise. Now, I think that is very valuable. It's very valuable to have that individual who is an expert, but it's also valuable to disseminate knowledge and to understand the limitations of transportation, so many logistical limitations of saying, well, if I live in, let's say, Oklahoma, am I going to travel to Cincinnati? Am I going to travel down to Houston or to Dallas, or where am I going to go? Now, what we often do, for example, in some parallel clinics, I participate in a couple of other specific neurogenetic clinics, is that we have sometimes these multidisciplinary care clinics that are set up with the intent not of taking over care, but really formulating recommendations to guide and to connect with your neurologist locally. Because I truly believe that part of the mission of Cure Syngap, part of the mission that we all have is to disseminate this knowledge. Now, for the sake of understanding up front, this is your day-to-day care. This is very different from the natural history studies. This is the stuff that your insurance pays, or this is the stuff that Medicaid or whichever setup you have, self-pay or whichever other support is supposed to be paying and caring and supporting based on the true and factual clinical needs. And you'll see the difference with that. Now, unfortunately, we do not have defined clinical care guidelines as of yet that are, let's say, published in the literature as evidence-based reviewed, but there are forms on your desks, on your tables right now with clinical recommendations that we've elaborated, which I think are a super powerful tool. If you flip it over, there's a QR code, I think, on the top right. It's a super powerful tool, particularly for families, to bring over to your neurologist appointment, because even though they are not let's say the peer-reviewed clinical care guidelines, they do have the information and even a setup for you guys to guide your neurologist, the person who is taking care of your child, to understand what testing should I get, what should I look out for, what should I understand about the evolution of Syngap over time. Now, we are building on a lot of these things, but when it comes to care, which is the emphasis of what the standard of care is, we're looking at how do we handle all of these other symptoms, the epilepsy aspects, the behavior, the development that come from this why, which is Syngap. So we are all about care, we are all about dealing with these comorbidities. Now that's different than your natural history studies, I guess. And I think the key word over here is they are truly observational. In nature, they are purely and sincerely observational. That means we are there to learn about a condition, in this case about Syngap, based on what your child and other children are able to furnish us with. So we have a standard approach. We participate in other natural history studies ourselves in Texas Children's, and in principle it is the same practice of we have a standard set of tools that we are collecting. So sometimes it may feel tedious for families to participate and say, hey, I'm filling out 25 forms. This is consuming a huge amount of time. This is a lot of work, but it is a lot of work that doesn't necessarily deliver something upfront in exchange, right? You go through all of this process and sometimes you feel, we spent 2 days and we only got a couple of words from our neurology team or whatever it is. And that is by design. This is not because we are not looking to be supportive, but this is because the data here is taken in order to support and understand Syngap, not understand, let's say, John or James with Syngap, but to understand Syngap as a whole and to bring this information out in future to help all children that are affected. It tends to be very different in the sense that it's in approved sites only, right? So this has some sponsorship. Someone is paying for this outside of your insurance or your own pocket, so to speak. And this is based on, again, standard questionnaires, but also a standard follow-up timing and whatnot. You do not have access to this data up front in the same way as, for example, if your physician has Epic, that you can just download MyChart or any other platform on an app and you can review their notes and whatnot. This information typically goes into some central database, right? So I believe our colleagues at CHOP are the ones who are holding the data for the, or you know, who let's say, who administer the data for the promise. But you know, in this context, this data goes into a central repository and that data is utilized for the purpose of research and understanding things in the longer term. So as I mentioned, there's no clinical care that is necessarily provided. This is observational for the most part. Now, how does that differ from clinical trials, which is a little bit of what the prior presentation had discussed? You know, the big difference is this is interventional, but at the same time, we are collecting information that has to do with your child, but not intervening on that information necessarily. This is helping us understand how a medication, an ASO, a gene therapy might help impact the condition as a whole, right? Again, this is something where it's not coming out of your own pocket. It should be coming out of the sponsor. The sponsor often is a pharmaceutical company or co-sponsored by a foundation, a pharmaceutical company. And as Lindsay very, very eloquently explained, you know, things are changing in the trial designs when it comes to rare or infrequent conditions. It is a little bit different. Now, what's sometimes frustrating to the families in which we participate in phase 1 and 2 versus phase 3 studies is my child going to receive the medication or the treatment or the trial? And that is one of those other aspects of clarity of saying that oftentimes if we're in those open label, that means we know if they're going to be receiving the medication up front where we're testing for mostly for safety but also a little bit for efficacy, then we all know what's happening. But there will come a point where if we're in the phase 3 in the really testing it versus the standard of care or versus a placebo or something like that, neither your physician nor most of the personnel in the investigation, nobody is going to know whether your child is receiving it or not at some point in time. And this is a point of frustration, I guess, for everybody, but this is by design, once again. This is how trials go. And oftentimes this is something that, you know, if we see compelling results, it becomes evident and the trial may be ended more promptly. Now, what care is delivered during clinical trials is care related to any conditions believed to be the result of that clinical trial. And that is care assumed by the clinical trial site typically, right? So for example, we are a site for an ASO for Angelman syndrome, and if we have someone who has a complication related to this, let's say examination or whatever it is, then we care for that. But most of our patients in our clinical trial, they're not cared for necessarily, or not most of our, a portion of our patients are not cared for by our clinic. So they will return to their local neurologist in Northwest Texas or somewhere else for the continuity of their care. So again, this is interventional, but those interventions are both the research medication as well as interventions related to the care that may come from that research medication as a whole. So in summary, really, those three interventions, the standard of care, the natural history study, and the clinical trials, are complementary to one another, are things that are part of this big maze that unfortunately a lot of families have to navigate. I think the first and most important thing is to establish a close bond with your standard of care folks, drive that care, and be involved in the community to understand, am I due to participate in the natural history study, and am I due to participate in some of these other clinical trials? I hope that was helpful. So I got nothing else.